Hey everyone, I'm Jonathan Purtle. I'm an associate professor in the Department of Health Management and Policy at the Drexel School of Public Health. And I am going to talk about policy, dissemination, and implementation research with a focus on mental health, which is where my work mainly focuses. So I am proudly a former IRI fellow and consider IRI core faculty, Ross Brownson and Enola in particular, to kind of be my implementation science spirit animals. So I've gotten a tremendous amount from this program, and I'm really happy to kind of share some of the stuff I've learned and share my thinking and how it's evolved from a lot of it from IRI mentorship. So my burning research question and what I focus on in D&I is this question of how we translate good policy relevant mental health evidence into public policy, and so that it's really having impact and is not just information on a shelf or on a server. This is a question I've kind of always been interested in through my DRPH training and for a number of years before I'd even heard of implementation science. Then I learned about implementation science and found out that this is a thing, and that was really useful for me in helping find frameworks and funding sources and kind of a real way to kind of build a career focused on this research question that I've been really passionate about. So I'm kind of, my work focuses on policy, and it also focuses on dissemination. This is kind of my subjective appraisal of the field. A lot of what I'm going to talk about today is more dissemination than implementation. We have a lot of implementation research and really just a teeny tiny bit of real, true, focused dissemination research. In terms of different levels of focus in implementation science research, I still think maybe 75% or so, the majority of it is really focused on clinical settings, maybe 20% at the organizational or community level, and just maybe 5% or so really focused on policy. So what I'm trying to convey here is, there's a lot of room for growth and development in the policy-focused D&I space. So early on, when I started to get into this area and decided I wanted to try to do policy D&I research, we thought it'd be a good first step to see, well, what has been funded to date. So we analyzed all projects funded through the D&I program announcement, looking at NIH Reporter. And long story short, we didn't find much focused on policy. Over 8 years, we found 12 projects that in some way were explicitly focused on policy, but really in reality, I'd say only 2 of those projects were really actually focused on policy. So that little dotted line at the bottom, that is funding for policy D&I, and that big dash line is all D&I funding. But there's some good news in terms of growth of the field. Kimberly Hoagwood and colleagues replicated our search terms, and they found 10 new policy D&I projects in just a 3-year period between 2015, where our analysis stopped, and 2018. So there's growing interest in the area, which is wonderful. Also want to note, William T. Grant Foundation does and has for a while funded work around research translation and policy in particular, with a focus on youth. So they are other good place to look if you're interested in work in this area. So the bulk of my talk is going to be about what I call policy dissemination research. And a lot of this is about dissemination with a focus on policy and mental health. But I'll say, what I'm talking about in terms of approaches to dissemination research, I think really apply to any topic, not just mental health, and really to any kind of practice audience, not just policymakers. It's broader than that. So this is the policy talk, and to a degree also the dissemination talk. So what is dissemination research? Implementation gets more focus in D&I than dissemination. So what is it? So according to NIH, which seems like a good source to look to, it's the scientific study of the targeted distribution of information and intervention materials to a specific public health or clinical practice audience. The intent is to understand how to best spread and sustain knowledge and the associated evidence-based interventions. So really I take this as, dissemination is about communication. It's about the spread of information and changing things like attitudes and knowledge and things that we would expect to change from communicating information effectively. Whereas implementation, per the NIH definition, is the use of strategies to adopt and integrate evidence-based health interventions and change practice patterns within a specific setting. So I see this as implementation being more about behavior and doing things to change behaviors. Whereas dissemination, of course, we want the information we communicate to, of course, ultimately change behaviors. But I think in dissemination research, especially with a focus on policymakers, because policymakers' behaviors are so complex and influenced by so many different factors, changing things like knowledge and attitudes are sufficient outcomes for dissemination. And I kind of see it as opposed to D&I, D arrow I. So if you disseminate well, you disseminate information about evidence in an effective way, that cultivates an environment that is ripe for effective implementation and subsequent behavior changes along the lines of what we hope to see. So the bulk of my talk will be on what I've called kind of this staged approach for policy dissemination research, or what I've also called data-driven dissemination. And this three-step approach kind of emerges from our trying to figure out the types of studies we should conduct and in what order to generate knowledge that would be useful from a policy dissemination perspective. So this is kind of like post hoc after, asking different research questions and figuring out what makes sense. We kind of came up with this typology. 3 types of research that makes sense to do in sequence, but this is also an iterative process. So formative audience research, audience segmentation research, and dissemination effectiveness research. So I will walk through examples of my work in these areas. I am not the only person doing work in this area. I just use my work because it's focused on mental health, the focus of IRI, and of course I'm very familiar with my own work, but I'm not the only game in town. Other people are doing great work in this area as well. So first, formative audience research. So the goal here is to just generate data to inform the design and delivery of dissemination materials. So this is really descriptive research, which is not to say it's not unsophisticated, but really it's descriptive. You're characterizing your audience. So what do you want to characterize them on? I think a few things, and this list is not exhaustive. But one is, their awareness about an evidence-based intervention materials, or the problem that the intervention seeks to address. So if an audience, doesn't perceive an issue as a problem, they're probably going to be less likely to get on board with the intervention that is intended to address that problem, right? So sometimes you need to problematize first, and it'd be good to know, to what extent does your audience perceive this issue as a problem? To what extent are they knowledgeable about it? So this is an example. A lot of the data I'm going to present is from a survey of 475 state legislators we did in 2017. So here, this is an example. This is a paper where we asked these legislators about the extent to which they thought that 4 different adverse childhood experiences were risk factors for adult behavioral health issues. There's a lot of evidence showing that this is the case, that ACEs are these risk factors. There are ways to intervene. But we want to know, do legislators know this? To what extent are they on board with this? And as we see, for some ACEs they are, and for other ACEs they are not. So this information could kind of signal, all right, we know that, witnessing domestic violence and childhood neglect can be pretty major risk factors for adult and adolescent behavioral health issues. We know about policy strategies to address those issues. Perhaps we need to emphasize that a bit more. Next, attitudes towards the intervention or towards the issue that the intervention seeks to address. So for example, Everett Rogers constructs from his diffusion of innovations theory of relative advantage, complexity, triability. All of these are quote unquote attributes of perceptions of attributes of the intervention. These are things that could be assessed in the dissemination study, which could then inform dissemination practice. So again, an example from our legislator survey. So our evidence-based intervention here that we focused on was state behavioral health parity laws. We focused on these because they're an evidence-based intervention that's recommended by the U.S. Community Preventative Services Task Force. This study was an R21 funded by NIMH. It went to the Dissemination, Implementation, Research, and Health Study section. And with that, we felt we had to kind of pick an evidence-based thing to focus on. So we focused on parity laws. So here, these is, we assess the extent to which legislators thought that these laws increase access to treatments, which evidence shows they do, the extent to which they don't increase insurance premium costs, which they don't. And also because parity laws, what they do is they're expanding coverage for mental health and substance use services. We were curious about the extent to which they thought these services were effective. And again, this is just, descriptive, formative research to characterize the target audience. Measures of adoption, or in the case of policy, support for a specific policy or intervention. In the policy space, I think, support is a kind of a decent endpoint indicator because, as I said, if you think of adoption as the behavior, so, a legislator introducing a law, a lot goes into that. in terms of voting yay or nay on a law, a lot of goes into that as well. And I think you kind of get too far afield from what dissemination could influence. But I think if you disseminate well, you could cultivate support for a specific policy or a specific evidence-based intervention. So you could assess that through survey research. So here, in this study, our outcome variable was state legislators' strong support for behavioral health parity laws. And the way we kind of set this up analytically, that attitude, that kind of attitude or indicator of adoption, depending on how you think about it, served as our outcome variable. And then we looked at how these other attitudes and also fixed characteristics like ideology were associated with the adoption indicator or attitude that we were interested in. And lastly, very concretely, in this formative audience research study, dissemination, getting concrete information about what your audience wants from dissemination material. So like, what does a policymaker want in a policy brief? Who do they trust receiving it from? How do they want to get it? Do they want podcasts? Do they want stuff mailed to them? Do they want emails? Just very concrete descriptive information that could inform dissemination. So here is another example. So we did the survey of state legislators I mentioned, but also a survey of state mental health agency directors over on the executive branch of government. And we asked them, if you were to receive evidence about mental health and substance use issues, what would you want in that information? What would you want in the policy brief? And here, just a breakdown of the variables dichotomy. So that's formative audience research, again, descriptive, and the goal really characterizing your audience and figuring out, with an eye towards how can what we learn inform how we more effectively disseminate to that audience. Next is audience segmentation research. So audience segmentation research the goal is to understand how dissemination materials or strategies might be tailored for different subgroups within a target audience. And I'm not making this up. This is very standard practice in marketing and advertising and health communication. And the general idea is pretty simple. It's that, you have this target population. That population is heterogeneous in their knowledge, attitudes, and behaviors related to the issue you care about. And audience segmentation is just an analysis technique to identify subgroups that have similar characteristics. And the idea is you identify these subgroups, and then you can tailor dissemination strategies for the different subgroups, and the idea and evidence supports that, tailored strategies are more effective than one-size-fits-all communication, or in our case, dissemination strategies. And there are two broad approaches to this: demographic separation and empirical clustering. So in demographic separation, you're just taking your target audience and you're stratifying them on some known demographic variable. So here, again, this example of the survey of state legislators about their attitudes related to adverse childhood experiences. And here we just stratified our survey sample by their ideology. There is an ideology item at the end of the survey, and we see that liberals, moderates, and conservatives, especially conservatives and liberals when compared, think about these issues differently, and thinking about how we might disseminate evidence about this issue differently to liberal and conservative legislators. Then there's empirical clustering approaches, which are more sophisticated. Here, you're using something like latent class analysis or k-means clustering to just see how different variables hang together. So it's a little more nuanced, it's a little more sophisticated. The segments you identify may be more meaningful. The caveat, however, is that, with demographic separation, you're stratifying your audience based on some known non-latent observable variable, right? So we could do the same thing as I just showed by political party. You look at any random legislator in the US, their political party, and that could provide indication of should you give them the Democrat tailored or the Republican tailored policy brief. With empirical clustering analyses, you need some way to link your segments and your clusters back to some identifiable variable. So if you pick out some random legislator in the US, you have some sense of what one of the segments you create through an empirical clustering analysis, they have the highest probability of belonging to. So in this study, and I'll walk through this just real quick, again, we took our legislator data, and our real question was, are there different segments of US state legislators when it comes to how they think about mental health and substance use issues? And the so what being, how might we disseminate evidence about these issues to the different legislators in different ways? This was totally post hoc. We got the STAR 21, we did the survey. Through both of those, I hadn't heard of this type of analysis. I'm sorry, hold on one second. Then I saw a really cool paper from the communication science literature where they did this about climate change. And I reached out to the first author saying, hey, you know, can we do this with our data? Does that make sense? And he said, yep. And we kind of just did what they did, which is often effective, but with a very different population and a very different issue. So the way it works is, I'm not sure who's done a latent class analysis. It's kind of a fun process in the sense that, you know, you pick the variables you want to put into it, and then you put it in the model, and then it's this quantitative exercise. The model tells you how many segments, you know, have the best fit, and then it tells you the distribution of those variables across people in different segments. And then it's like this qualitative exercise of looking at those patterns, at those distributions of variables, and then naming these different segments, thinking about what the most salient features are and kind of naming each one. So our 3 segments, based off the variables we put into this, which I'll present on the next slide, we have the biggest group, which is budget-oriented skeptics with stigma, passive supporters, and action-oriented supporters. So what am I talking about? So on the left side here, these are the variables that we put into the LCA. In this case, all of these were dichotomous. That makes it way easier for interpretation. You can't have continuous variables in these. It just can be more challenging to interpret. So we had a dichotomous variable that was an indicator of whether or not legislators thought that mental health and substance use disorder treatments were effective. We asked 4 items about 4 5-point Likert scale items about stigma towards people with mental illness, then calculated a score for each legislator, and then assigned each legislator in our sample to the quartile stigma score that corresponded with their score. We asked them about a range of things that might impact whether or not they influence whether or not they are supportive of a behavioral health bill when it's introduced in the legislature. We were interested on whether or not they indicated the extent to which the bill was going to impact the budget, and the extent to which it was based on evidence. We asked them, we gave them a list of, I believe, 17 issues, and we asked them to pick the 3 that were the biggest, the most important issues for legislative action in their state. And we were interested in whether or not they picked mental health and or substance use. And we asked whether or not they ever introduced a mental health or substance use focused bill. So here we're looking at, you know, these are the segments and these are the distribution of these variables across these segments. So just a little more technically, the way it works is the way we did it. Every legislator in the sample is assigned a quantitative probability ranging from 0 to 100 of the segment they have the highest probability of belonging to. And we just assigned each legislator to the segment they had the highest probability of belonging to. Then we also did the same thing, treating that probability as a continuous variable, and we largely found the same thing. So this group is budget oriented because above and beyond legislators in the other segments, they said that the extent to which a bill was going to impact the state budget had a lot of influence on whether or not they support a behavioral health bill. They have the most, they are the most skeptical towards the effectiveness of behavioral health treatment. So the smallest proportions in these segments saying that they thought mental health and substance use disorder treatments could be effective. And they also have the most stigma towards people with mental illness. So we use these 4 items about social distancing, preference for social distance towards people with mental illness and perceived dangerousness. They've been widely used in public opinion surveys, and this group had by and far the most stigma. So this other group, the action-oriented supporters. So they're action-oriented because these are the people introducing mental health and substance use bills in their legislature. They also, not surprisingly, they're introducing bills. They prioritize these issues, and perhaps a good thing, you know, these are the people developing and introducing bills and prioritize mental health and substance use bills. At least they say they care a lot about evidence. And lastly, the passive supporters group, they are passive because they're not really introducing mental health or substance use bills, especially substance use focused bills. They also care about evidence. And the interesting kind of most salient feature of this group is they have the most faith in the potential effectiveness of behavioral health treatments. So I could talk about this at length, but I won't here. But all of this, you know, the so what is to inform how we disseminate evidence about behavioral health issues to different types of state legislators. So lastly, dissemination effectiveness research. So here, the goal is really just to determine which dissemination strategies are more effective than others, comparing A versus B versus C. And what are the outcomes of a dissemination effectiveness study? So they could be things like perceptions, attitudes, or perceptions of appropriateness or acceptability or awareness. They could be indicators of adoption as collected through self-report in a survey, or observing different types of behaviors. So, little things like, you disseminate evidence in 3 different ways. That those differences are maybe you use a narrative versus a data-heavy policy brief, and you email it out to legislators, and looking at things like email open and click link rates across the conditions gives you some information about effectiveness. Of course, that's not meaningful in and of itself, but it's kind of a very proximal indicator and something that you can get data on among everybody without having collect primary data, which is of course challenging with policymakers. Also, while it's challenging to get survey data from policymakers, a pro is that a lot of what they do is on the public record. And you can look at quote unquote artifacts of the policymaking process. So public statements, legislative committee reports, social media posts from legislators, and get a sense of the extent to which their behavior varies across study conditions where they had information about a specific issue disseminated to them differently. If policymakers are not your audience, you could disseminate in different ways to different practitioners, and then look at claims data, for example, as an unobtrusive indicator of behavior change and seeing how that varies across the study conditions. So here's an example from my work focused on policy and dissemination effectiveness. This was supposed to be, we were supposed to be doing this now. We were just about to press go, and then COVID hit, and we realized this is not the time to be doing this study. We're probably going to see no effect. Everyone is busier than they ever have been. So we're holding off till next year. But in short, it's a cluster randomized study. So states and state legislatures particularly are the units being randomized to one of 3 conditions. And then within each one of those conditions, all legislators on health, child welfare, and education committees will be randomized to a condition that corresponds to the condition that corresponds with their state. And what we're looking at here is it's evidence about adverse childhood experiences and behavioral health. And what we're really interested in, how much does providing state level data as opposed to national level data matter? And how much does it matter if, when you disseminate information, you include cost estimates and you put things in economic terms? So we're post-mailing them these policy briefs that correspond with the condition to they were assigned 4 times over the course of what will probably be about 10 months. We're emailing them each time we post-mail them. And then we're going to look at things like email open and click rates. We're going to look at their legislative behavior using this database called Quorum that compiles all these legislative artifacts. And also we're going to try to do a post survey as well. We're probably not going to have power to really look at differences across the 3 groups because response rates are always low. But it's another indicator that if we do see things go in the direction that we think they are, just another indicator that that our hypotheses that state tailoring and adding economic information works and is more effective than not. So I was asked to give a little bit of background information about some of my other ongoing projects. This one study, it is a project as part of a larger P50 that Kimberly Hoagwood and Miriam McKay are PIs on. So in this study, I would consider it a dissemination and kind of an implementation study. It doesn't fit squarely within any of the dissemination studies I just talked about. But really what we're doing here is trying to understand the determinants of using research evidence in making policy decisions about children's mental health in state agencies. So just quickly walk through the aims. So one, we just want to assess the extent and correlates of research use in state mental health agencies. So to do this, we did a big survey of state mental health agency officials and Medicaid officials and health department officials in winter 2019. We're analyzing those data now. We are going to go into the field. Again, this was paused because of COVID, but we're going to be doing it pretty soon. I'm going into the field to do qualitative interviews in 4 states. So it's a comparative case study approach to explore those findings about the determinants of using research evidence in different ways across different phases of the policy process in greater depth. And then informed by those findings, we're building a agent-based model with folks at WashU. So this is really Doug Luke, who you may see a presentation from, and Todd Combs, who are absolutely instrumental in making this actually happen. We're going to build this model and kind of manipulate in this model kind of large-scale dissemination interventions. And maybe things, we're still working out the details, but things that, it might be hard to really do in real life, a randomized controlled trial of. So for example, one thing that emerged from our data and our findings is that, partnerships between researchers and policymakers are often lacking and perceived as really important. And a lot of policymakers in our survey said, I don't use research evidence because the questions that researchers ask are not relevant to the decisions I make. So in this model, we may, manipulate different levels of partnership between researchers and policymakers and manipulate the policy relevance of research evidence in this model and see, based off the parameters of the model that we put in there that are informed by our quantitative and qualitative findings, how that changes use of research evidence practices. So I want to talk a little bit about policy implementation research. So policy implementation research, I think, is even less studied, especially in the area of behavioral health, than dissemination research. This is a great paper if you're interested in policy and implementation research. This paper really, compares policy implementation research, how it's been thought about in the D&I space, to how it's been thought about in the political science space, where they've been thinking about this for a while. The main difference being that, the main difference being that in political science, it's very descriptive and it doesn't have that eye towards action as it does in implementation research, and definitely doing something. But it's a great overview paper. So just to share some thoughts about different types of policy implementation studies. So a policy implementation study may be purely descriptive and describe the process through which a policy has been implemented. It could also identify policy implementers' perceptions of things like enforcement or adherence or adaptation of a policy. I think this is really important for policy impact studies that economists often conduct, because it gives sheds some light into the black box of, we can see a policy has been passed, we can observe an outcome, but we're not going to really see an outcome if the policy hasn't been implemented. You could assess barriers and facilitators to policy implementation from these implementers. You could assess perceptions of the acceptability and feasibility of policy implementation strategies if where you're planning to go is implementing some sort of policy implementation strategy. You could also, of course, do effectiveness studies where you test different implementation strategies and see the extent to which one has more impact on implementation outcomes related to a policy than the other. There's a lot of room for growth and research in this space. So this is an example of one of these studies that should be funded in September by NIMH. I'm doing this in collaboration with Nicole Stadnick, who is also an IRI fellow at UCSD. So what we're interested in here is these earmark taxes for mental health services. So in short, these are taxes that are, the authorizing legislation is usually at the state level, it could be at the local level, but pretty much what it does, it taxes one specific thing and all that money goes into a pot that can only be spent on mental health and or substance use services. So in California, they have this millionaire's tax where all household income over $1 million is subject to an additional 1% tax, which is for mental health services. In Washington state, state legislation authorizes counties to increase their sales tax by 1/10% to fund mental health services. And we're really interested in the kind of implementation of these policies. The big picture implementation science research question being, like, can you throw money at a problem? And if you suddenly have a lot of money, but not the appropriate scaffolding to spend that money on ways that support, uptake of evidence-based practices, what are the barriers and facilitators to that? So this will be an R21, has 3 aims. The first aim is to do what's called a legal mapping study to really systematically identify all jurisdictions in the United States that have implemented earmark taxes for mental health services. Then we're going to do a survey of county mental health agency leaders' experiences implementing these taxes in all these jurisdictions. We're going to be using the EFIS framework to inform that. We're also going to assess the acceptability and feasibility of policy implementation strategies one plausibly might want to use. And then we're going to kind of pull all this together to develop a conceptual policy implementation framework to improve the design and implementation of earmark taxes for mental health and substance use services. Kind of the motivating factor behind all of this is, the number of jurisdictions across the US implementing these things is increasing. We know that there's a lot of public concern about mental health issues, and we see this as a type of policy that may be kind of rolled out in more jurisdictions. So this formative study really seeks to generate knowledge that could improve the impact of those policies if that does indeed happen. And just last little bit here, thinking about context in policy-focused D&I research. So I think there's kind of a clinical bias, if you will, and a lot of implementation science when thinking about context. So often, the focus is the intervention, some very concrete evidence-based treatment. The adopters are people like clinicians and organizational leaders. The inner context is stuff like implementation culture and organizational climate. Outer context is policy. I'm sorry, hold on a second. You can say hi at the end, okay? And policy is the stuff at the outside, like policy and policy makers. In a policy study, it changes a bit. So the intervention is the policy itself, or a policy that's evidence-based or evidence-supported. The adopters are policymakers, right? So they're legislators or administrative policymakers. The inner context is the stuff surrounding those policymakers. So that may be legislature politics or the governor's agenda. And then if policy is the focus, the outer context gets much, much broader. So it's things like public opinion, media coverage about an issue, all of that stuff. So what I really want to convey here is, in D&I research, often policy is like this vague thing on the outside, but in a policy-focused D&I study, all of that switches. And what is on the outside then gets much, much, much broader and much what would be traditionally more farther afield from what we consider implementation science. But I think it's still highly relevant to implementation science questions. So just a quick example here of thinking about this. So we know that public opinion influences policy making and matters from a policy development perspective. And implementation science is really about, the use of research evidence and evidence-informed or evidence-based practices. So kind of mashing these two things together in this study, what I was curious about was the extent to which the US public wants to see evidence play a role in health policymaking relative to other issues. So we did a public opinion survey of about 500 people who are participants in this SSRS panel to get a sense of what they think about the role evidence should play in policymaking and the extent to which they think that evidence should play a role in health policymaking. Policy being focused on just US Congress for this particular study. So what do people think that should have a lot of influence on health policymaking? Well, evidence. That's great. One hand surprised, but other hand not surprised by this. So evidence and citizens' desires. This study was, very, very kind of a first cut at this. Just looking at this always raises the question to me, well, what happens when evidence and citizens' desires completely clash, as they often do? What do people think then? But at least in theory, people say they want evidence. They don't want policy to be influenced by pharma and insurance companies. And not really doctors or concerns about the budget either. So that's what they think should have a lot of influence. What do they think actually has a lot of influence on policy? Not evidence, not citizens' desires. So what we see is kind of this inverse correlation, which really just the takeaway from this is that, the public seems very dissatisfied with the fact, what is influencing health policy making in Congress. And the so what from a D&I perspective is that there is public demand for policymakers to use research evidence. And we know that public opinion influences policymakers' behavior. Thus, maybe we can use public opinion as a tool to try to get policymakers to use more evidence in their work and make more evidence-informed policy decisions, especially elected officials. So just lastly, concluding kind of areas I see as policy D&I methods, innovation areas, and just kind of ways to think about moving forward. So first, I think you can think about analyzing policy-making processes, which is particularly important to dissemination research, right? So with dissemination, you want to infuse research evidence into a policy-making process. And dissemination research, like I presented today, I think can help do that. Also, lots of room for policy implementation research, figuring out how to improve the implementation of public policies. And lastly, thinking about policies, in non-policy focused D&I studies, policies, it does make sense to think of them as outer context, but thinking about ways that we can be really systematic in characterizing what the policy exposures are that might be affecting a clinical outcome related to implementation. And ideally, as knowledge grows around these areas, we generate knowledge about how to better implement policy, and then we build that into policies themselves. So policy implementation is less left to chance and is more guided by concrete implementation. So I will conclude there. Unfortunately, Theo, who you may have seen quick cameos of, has left. I was going to introduce him at the end. But thank you for your time, and I look forward to chatting with all of you. Thanks.